You just have to subscribe for a month, which is like $15, and you can do whatever you want on there. It's the cheapest of the cheap.
So basically in the last 5 years I've gotten very interested in cutaneous nerves, and I've been looking for ways of assessing that stuff, and I've kind of realised and sort of decided that essentially every movement, passive or active, is a neurodynamic assessment in some way, shape or form. If you think about the fact that nerves exhibit intraneural pressure and nerves keep very close track of that intraneural pressure, if a nerve starts jumping up in terms of intraneural pressure too quickly, the brain or the spinal cord or both is going to hold the brakes on.
Right.
And so this is theorised to be the limitation of movement that we're assessing today. And specifically, the limitation will be in the cutaneous nerves. Right. So essentially, I'm asking you to forget that joints and tendons and ligaments and muscles even exist, and that if the limb moves there, then the nerves in the layers of skin are okay with that movement. If the limb does not move there, then the nerves in the layers of skin are not okay with that movement.
Right.
Right. And so, if then you assess and decide, that may well be a restriction in this cutaneous nerve, or there's these 2 or 3 cutaneous nerves, whatever it is, and you do some work with those nerves, and then you see a change. Obviously, none of the tendons, ligaments, muscles, other stuff actually mattered, because now you've got the range of motion there. All that mattered was, what is that nerve saying to the central nervous system, and how okay with what that nerve is saying is the central nervous system. Is it okay with taking enough of the brakes off to allow motor units to lengthen, or whatever feels stuck? Like I know, when we did a little bit of this assessment a long time ago, you're, oh man, my hamstrings are so short, and I'm like, yeah, cool, I get that, but I reckon that, if we put you under general anaesthetic, same as anyone, we'd be able to take your leg up to 90 degrees.
When was that? 'Cause I don't think my hamstrings are short anymore.
Okay, cool. That was maybe 3 years ago,
right.
two and a half years ago, something like that.
Cool.
That was we did a little bit of work around some of the intercostal stuff. You'd had some weird stuff wigging out there sometime a few months earlier, I think.
That's right.
You're like, it's not much going on. And we ended up with doing a little bit of work around the front of your hip.
That was really nice,
And then last time we caught up with Anna, we did a bit of work around the front of your hip. And I still feel sorry about how much you leaped when I came across that one nerve. But there was just one that went ping!
Was it?
I was like, oh dear, I try not to do that to people when I'm assessing the nerves.
Was that around the ribs?
No, that was around the front of your hip as well, actually. Right hip.
Cool.
So
can I just ask, your definition of cutaneous, so when the nerve is in the skin, you're calling it a cutaneous nerve? Or are you calling it like when it's coming through the
so
what's your definition?
So I guess I would define a cutaneous nerve as the entire cell of a nerve where one end terminates in either the spinal cord or runs all the way up to hindbrain, midbrain, right? And synapses there. And the other end of that nerve is in the skin.
Right.
So it's part of a deeper trunk, it's part of a deeper peripheral nerve. Often there are some nerves that are only sensory, and there are very few nerves that are cutaneous sensory only. Lateral femoral cutaneous nerve and a couple others. All of these nerves do have non-cutaneous aspects, and yes, you can have problems with those too, especially like the saphenous nerve, I find, up in the adductor canal, before it hits the cutaneous layers. There's quite often tenderness and restriction in there. And then, like, are you working on the saphenous nerve there? Are you working on the medial branch of the anterior femoral cutaneous nerve? Don't know, man. There's so much overlapping architecture with all this. And then at the same time, how much of the change is happening peripherally, how much of it is happening in the central nervous system. Does it even matter? Because essentially, what is the division between the peripheral and the central nervous system? So the central and the peripheral nervous system, they are so intertwined. If you think about the fact that there's a cell going from your big toe to your midbrain, right? We can.
Big cell,
It's a freaking big cell, especially for some people.
It must be the biggest
Longest cell in the body. Yeah, absolutely. Yep. It'd be either part of the saphenous nerve or part of the tibial branch of the sciatic nerve. Right. Yeah. They both in the big toe.
Right, and lots of nerves end in superficial fascia too, hey?
So the superficial fascia is also innervated by cutaneous nerves.
Right,
so nociception in the external layer of the deep fascia, not like the deep fascia between muscles and stuff, but if you think about the deep fascia being the layer underneath the cutaneous layer, separating the investing fascia, and that being where the little aponeurotic rings happen that the nerves got to get through, that actually end up being a bit of a problem, right?
Yeah.
And you know, this is where, are you working with fascia, are you working with nerve, right? Because essentially, you know, you do need to open up those little grommet holes to help the nerve to drain better and to get better blood supply and to send more normal signals. But all you're really doing,
fascia and freeing the nerve, changing the stimulation of the nerve.
Yes, all you're doing is getting the fascia out of the way. You just want the fascia out the way enough that the nerve can be happy, and you're not changing fascia to do that. You're changing the physiology inside the nerve and hoping for a nerve that ends up better able to keep itself healthy.
And you're changing the physiology, you mean you're changing the pressure? Or
changing pressure, changing function, yep. So changing how the nerve is behaving, changing levels
what's the mechanism of that? Do we know?
Of which bit?
What's the mechanism of touch changing the state of the cutaneous nerve apart from, like, if we're changing the cutaneous nerve rather than the fascia? Do you know the mechanism?
There's two things that will be happening. One is stimulating the Ruffini's corpuscles, the stretch receptors,
right,
and that gentle, consistent input into slow adapting, low threshold fibers. So you're sneaking in under the radar nociception.
Yeah.
We'll be doing a whole lot of cool calming stuff in central nervous system, especially midbrain, hindbrain, insular cortex, because you're also stimulating the C tactile afferents, which also pretty low threshold. That's the stuff that responds very nicely to 3 centimeter stroking, 3 centimeter a second stroking in a whole lot of the noise stuff. And then the other thing is changing the intraneural pressure, because nerves are bundled together, axons held together in little fascicles by a bunch of fascia, and then a bunch of fascia holding all that together. You've got some adipose tissue in there for a bit of suspension, especially in the sciatic nerve. So you can sit on your bum, sit on your hamstring, and not end up with numb feet that don't work. And
it'd be a design flaw, wouldn't it?
Wouldn't it? Yeah. And then a whole heap of blood supply, because nerves are really energy hungry things. 20% of your calorific needs per day go to running your nervous system, even though it's only 2% of your body weight. And everyone talks about the blood supply to your head, and yes, that's really important, but all your nerves everywhere have that same high demand for oxygen and glucose, and if they're not getting that, they will start using other metabolic pathways which are less efficient, and then they start excreting things that are actually inflammatory in and of themselves, those metabolites, right? Start pissing neural tissue off, sensitizing nerves that are inside nerves, because of course nerves have got nerves too, nervi nervorum. They are classed into two things. They are nociceptors and they are baroreceptors, right? So obviously the nociceptors, you know, they're firing off for all sorts of reasons, and they're firing off for all the time. Brain's very good at pruning a lot of that out and not really reporting it to conscious mind. Which is where the pain experience happens, isn't it? Totally. But then you got baroreception as well, right? And this is specifically for keeping track of that intraneural pressure. And should that intraneural pressure start changing at a certain rate, especially, right? It can change from quite low pressure to quite high pressure, but if it changes slowly, it's not going to respond in the central nervous system is not going to respond in quite the same way. So if a nerve is too fat and swollen, and edematous inside of that nerve, it can get to the point where that fluid in and of itself is the problem, because that kind of pushes up against the grommet hole and occludes that, and then you start occluding the blood supply coming in, right? And if you can't get good blood supply in, that's what pushes the cell into metabolic crisis, and they start getting pissed off because they're manufacturing metabolites. So if you can open up that grommet hole and stretch the nerve to a point where you actually get lots of drainage happening, then you can drain that nerve, reduce the edema inside the nerve, normalise a whole lot of the intraneural fluid dynamics, changing the blood supply in, changing the lymph out, and just calming the farm, and a whole lot of reporting, because you drop a whole lot of stuff under thresholds that the central nervous system was not okay with, really, but was coping with, finding answers for, finding workarounds for. And so if you can reduce the need for all those workarounds, and use all those calming signals to also help the spinal cord withdrawal reflex dim down a little bit more, because that gets more and more reactive the more nociceptive input there is, and lots of that nociceptive input may actually be coming from inside nerves, right? Not just free nerve endings in tissue necessarily, right? They can too, but my suspicion is the ones inside nerves are probably a lot more important than anyone's really thought about.
Yes. I think a lot of pain is a metabolism problem, hey?
Yeah, man. Reactive oxygen species, reactive nitrogen species. You put that together with all of the other what's the word, endocrine stuff, and man, you can make some really cranky tissue, and you start turning up in the nerve roots and in the spinal cord and in the cortical structures, and man, people have a bad time, eh?
Don't they?
Yeah. So, I guess seeing there's 4 of us and only one of us knows how to do this neurodynamic assessment, I'll do it 3 times, and the first time I think I probably won't talk through what the nerves are necessarily. I'll just talk through what areas I'm kind of assessing and what I'm expecting to feel versus maybe what the subject is feeling, and then talk about
do me
and then talk about where the restriction is, and try a little bit of work, like maybe 5 minutes or something on maybe 1 or maybe 2 areas that seem pertinent, right? And then on the next person, I'll actually, rather than talk about what restrictions I'm feeling and stuff, I'll maybe talk through, these are the nerves I think we're assessing as we're taking them through this range, and sort of help you understand which nerves I think I'm assessing and which positions kind of relate to that.
Yeah.
And none of this is hard and fast. It's all a very inexact science.
Touch communication, feedback, and
yeah, for sure. Like a lot of DNM, it is about that communion of the 2 nervous systems, right? And the healing potential in that, and the ability to assess kindly as well, I suppose. Some of the assessment does get a little bit pokey in terms of the palpation, and often that's just to help people feel where we're working, because people are useless at feeling their bodies. What are you feeling here? That's all right.
That's so good.
No clinical relevance to whether or not it feels all right. What are you feeling? Does it feel numb? Does it feel tingly? Yes.
It's such a pleasure working with people who are curious and like, now I'm feeling this. Oh, now I can feel something in here, and it feels like this, and and they're like, oh, this is so good. The feedback's super helpful.
Okay. All right. Yeah. So. I'm just going to put my hands on your shoulders here, if that's okay.
Yep. So it's an inactive and embodied process, Hugh.
It is, entirely. So I'm picking just a little more tension in that left trap than the right side. Any more tenderness one side than the other?
No, just I'm like...
Right. I'm going to bring this hand and the smallie back here. Bring this hand.
Oh, sorry.
Smallie back, thank you. Just keeping that shoulder nice and relaxed. So a good amount of wiggle around that shoulder there. If you take that arm straight up front, thumb up, and coming all the way out to the side. Great, and keep reaching straight back from there. Great, so that shoulder blade kind of sneaks in nicely towards the spine as that sort of arm swings back further. Any tightness in that position?
A little bit anterior elbow.
Yeah, okay.
A little bit of upper trap.
Great, and relax the arm. I'm going to bring this hand back here. Keep that shoulder nice and relaxed. That's probably a bit wiggly at that side, hey? Does it feel any different to you?
Yeah, I think so.
Yeah, okay. I'm going to bring that arm up front, thumb up. coming all the way out to the side. So interestingly, that shoulder blade has moved a long way towards the spine already, right? That did not happen on the other side. If you keep reaching the arm back from there, it'll take itself to the rest of the way to that spine there. It's interesting, I don't think he actually got quite as much extension around that shoulder. Any tightness happening on that side?
He's got more scap mobility on that side.
Yeah, but there's something else happening around the front of that shoulder.
Yeah, this is
You can feel the difference.
restricted there.
Okay, so that feels more restricted, eh? On the
Yeah.
right.
nothing in the front of the bicep.
But there is that
On the
side.
left side.
Yeah, okay. So this is going to be a little more complicated now.
Yeah.
If you turn your head around to the right side here, tightness anywhere in particular? Yes. And if you go to the other side, looks a little more comfortable going that way?
Yeah.
Yeah, cool. Come back to the middle. If you drop your head to the right side, great. And go on the other side. So there's a whole bunch of tightness happening there, hey?
Mm-hmm.
Yep. Up through the neck, across the shoulder, through the neck. Yeah, nice. Okay, so bring the head up neutral here. Sorry, this is going to be a little bit pokey in here. You got the brachial plexus running down from between the scalenes here, and that feels ropey as heck on that side there, hey? Any more tenderness one side and the other?
Yep, right side.
Yeah, okay. We'll bring that hand smallly back. Let's bring a little more tension into brachial plexus. More cranky in there now?
Mildly.
Mildly, yeah. Okay. We'll swap hands. How does it feel that side?
Yeah, less.
Wait, this
Still
out.
a little bit like
Cool,
that's
alright.
doing something. But
So is there something going on with cutaneous nerves through the neck? Maybe. I suspect some of that restriction is actually more due to brachial plexus being a bit stuck somewhere.
Mhm.
I wasn't really intending on getting too into brachial plexus today. So we'll see what else we find.
You say that because of the tension you can palpate
I
on
feel
brachial plexus when you
that
wind
tension in brachial plexus, but I only really went looking for that because of that pattern of restriction I noticed around the shoulder and how that shoulder blade wasn't moving. Could have been coming from somewhere else, but that was probably my first guess, and it's a fairly educated guess, having done this a few times now. So, if you want to give yourself a little hug, hands up on your shoulders there, turn your whole body around to the right side. Great, and on the other side. Looks a little tighter going that way. Any obvious restriction? Okay, yes, nothing on the right. Nothing on the right side when you were going to the left side?
Oh, sorry. No.
Okay, come back to the middle. If you lean straight across towards the right side here, that looks pretty great. And go on the other side. That's good movement, apart from, it looks like the arming up there is a little restricted. Do you feel tightness anywhere in particular?
Kind of momentary, somewhere around here, but it goes
Yeah.
away. It's just
Okay.
when I first go into it. I feel
Yes.
it. Yeah.
We can get you sitting long-legged along the table here, so you got your bum right up one end, feet down the other end. And if you reach down towards your toes, you can drop your head forward as well. So that's pretty great spinal curvature up further, maybe a little bit of flat spot through there, which is pretty common. Really good mobility through lumbar spine. The angle of that sacrum looks great. Let's get you on your back. I'm going to scoot down just a fraction. Let's try this without a pillow first, I reckon. So we'll keep this leg nice relaxed here.
Doing the table out.
No, that's good. Anything in the calf, anything back in the knee, just hamstring?
Yep.
A little bit.
A little bit,
Yeah.
maybe behind the knee, but very subtle.
Yes. Just relax again. A little more movement that side. Anything calf, anything back in the knee, just hamstring?
Very mild back of the knee.
Okay. If we can roll over along in front.
Something random happening around here. Actually, that actually reminded me I felt something in the night when I couldn't lie on my left side last night.
Mm. That's interesting. Okay. So carrying on with stuff around hips here, and keep this leg nice, relaxed. Getting a little bit of tightness in the middle of the thigh.
Yep.
More towards hip, more towards the knee.
Slightly towards the knee.
Yeah, okay.
A little bit lumbar.
Something in the back as well. That's interesting. So that to me would say there's a bit of tension happening through femoral bundle somewhere, right? Probably in the cutaneous layers. Sorry, do you want to step across just a little bit there? Thank you.
Oh, sorry, bro.
Yeah, it's all good. There's not much hip height happening there, which is good. So I'm just going to pin the sacrum just gently here, extend that leg back, take it medial, a bit more resistance there, and a lot more resistance for that one. Anything cranky in your back with that last movement?
Not that one, when you went medially slightly.
Okay, yes. And does that feel like it's in the same sort of place, or is it somewhere else?
Can you do it one more time?
Yep.
Same place, I think.
Yep. Cool. And keep the leg nice and relaxed. So probably a little more tightness through that quad there. front of the thigh.
Yep.
Tightness in the middle. Anything going further up, further down?
Not really.
Go. Yeah, nice thing got me. That feels like good joint end range there. Good joint end range there. Good joint end range there. Anything in your back with any of that?
Lateral.
So further out than here?
Oh, sorry. Central lower back where the leg was going.
Oh, yes. I'm sorry.
Very mild.
Yep. So another interesting thing is how much tension ends up in QL when there's any tension happening somewhere further down, and sometimes a little bit further up as well. That feels pretty even for Anna there, I would say. Maybe there's slightly more tension in that right side, but it's pretty subtle. Nothing too pokey or sharp feeling with that?
No.
Great. Give me a nice breath in. A fair bit more rib expansion on that right side down low there. And another breath. Yeah, quite a lot more expansion on that right side in the middle there. Sorry for the tickliness. One more breath. Yeah, that's interesting. And then more movement on the left side, a little bit less on the right. Did you feel that?
Not really.
Have a go. You feel that left
Yeah,
side
yeah.
just keeps moving a little longer there, hey?
Apical movement on the left side.
Yes. Yeah, I reckon maybe that's something to do with that brachial plexus stuff that we found there. All right, I'm going to go over on your back again. So not really seeing a huge amount around the hips there. So I'd say let's carry on and make it more complicated then. Just going to keep your arm nice, relax here. So a little bit of tension happening around the back of the shoulder there somewhere. Anything tight, anything pinchy?
It just feels tight, but where is it? I think it's just tight around here. That I feel.
Generally around the shoulder there, hey? Yeah. So, a little feel kind of along that edge out there. So a little cranky feeling as we get further down there.
Just sort of a little bit tender all the way along.
All of that stuff, eh?
Yeah.
Okay, so we've got the axillary nerve running along the back of the shoulder there. Let's have a look at radial nerve here. Any tightness anywhere through the arm, through the forearm?
Yeah.
Yes. More tightness there now. Okay. Same place. Yes. Nice relaxed here. Tightness anywhere at the moment.
Mildly into the hand.
Yes. Okay. Pretty tight in the elbow. Let me know if anything else happens.
No.
In the elbow.
A little bit in the hand now.
Elbow as well.
A little bit.
Okay. So elbow would be what I would expect. So that's an abnormal neurodynamic finding there. And that ulnar nerve movement looks pretty great there.
He didn't say that out loud, Anna.
No.
Just said it. Yeah.
Nothing abnormal. No. Right. So that feels just a fraction tight compared to the other side, but it's pretty subtle. That's quite a lot tighter on the other side there, hey?
Yeah.
Same general pull around outside the shoulder, around down. Something else happening?
Maybe slightly more posterior shoulder.
That doesn't feel as bunged up to me as the other side. Tenderness?
Yeah, just little spots.
How does that compare to the other side? Which is more tender?
Left, I think.
Okay. So, that radial nerve, there's just a little bit of tension, getting that wrist into full flexion there. Quite a lot of tightness through the forearm now.
Yeah.
More tightness now.
Yeah.
Yep.
Yep.
Okay. Sorry.
That was like.
Okay. Yep. So you definitely got a bit of adhesion around that radial nerve for some reason. Tightness anywhere there.
Mild flexor forearm.
Yes.
Easing off and yep, hand. Another hand.
Yep.
Mild elbow.
There's a little more limitation with that one than the other side, which is interesting. The nerve movement's pretty great.
How the heck do you hold all these findings in your head here? I would have had to run to my computer like 7 times.
Because I do it 100 times a week.
Okay.
Yeah.
So I'm going to keep it nice, relax here. A little bit of resistance to that full external rotation, but it feels pretty good. That's probably a little more tightness than I'd like to see with internal rotation. It'd be nice to get your foot flat on the table there. Ignoring my pressure down here, any obvious tightness? Stuff around the outside of the hip there. Yep. That's pretty good wiggle through your low back. Pretty good wiggle around that hip. The sleek here drops out so much easier, hey? And we can get that foot right down on the table there, no worries. No tightness happening that side, I'm presuming?
Very mild.
Yes, okay. And the other side didn't feel bad, but you can probably feel just how effortless that wiggliness in both directions there is. If we come back to this side here, you can feel that little bit of resistance that sort of just takes that little more effort with that, right?
Yeah.
Yeah. Okay. So, just going to keep it nice, relax here. If you get any pinchiness in front of the hip.
Yeah.
Yeah. Okay. And if we go to the other shoulder.
Yeah.
Worse going that way?
Yeah.
Yeah. Okay. And nice, relaxed.
What are you assessing for? What's Anna come in with?
A little bit.
What, like?
I don't care.
You don't care?
No. This is.
Yeah, you do. You totally care what she's going to do.
Well, not for the purpose of
Yes,
this.
but it's not influencing.
We're asking the cutaneous nerves.
Right.
What they are thinking is okay in the body at the moment, right?
Yeah.
Does that make sense?
Yeah.
That's similar to that.
If someone comes in with something, yeah, hell yeah, I do a targeted version of this, right? I don't necessarily assess all of this on everyone.
Right.
That would take my 20-minute session.
yeah, but I mean, like, so most people are coming in saying I've got this.
Yeah.
You're treating that.
So you've got a jumping off point.
Right.
So you can take portions of this.
Yeah.
And you know, I'd encourage you to, you know, if you think something's going on around a limb, assess all of it, right?
Yeah, you got it.
Because sometimes you think it's in the front and it's in the back. Sometimes you think it's in the back and it's in the front.
Yeah.
And that's why I like this stuff, because you know it's a little more objective somehow. You know, even though I'm relying subjectively on what I'm feeling, you're verifying that often with the patient as well. And they're like, yeah, I feel that as well.
But you're giving more weight to what you feel than what Anna feels.
Yeah.
I don't know.
Depends on their ability to
It very much depends on their
articulate
ability.
and sense.
I guess I'm giving weight to the number of assessments I've done prior.
Yeah, I get that.
And having built up a reasonable
weight
assessment
of experience.
what,
Yeah, absolutely get
what
that.
a relative normal should be.
Yeah.
How's that pinch compared to the other side?
Less.
Okay. Certainly more restriction in that movement. I don't really feel like we're getting into the same range. That was pretty pinchy that way. Yeah. Compared to the other side, that one?
Still worse.
Still not as bad. Okay. So.
Random, like, vague pains happening around here.
When I was moving that right leg around,
Yeah,
or just
but
as you're lying now?
I wonder if it's just from the other things and because of whatever is already.
You've got something going on, and we've been messing with nerves everywhere.
I think so.
Yeah, for sure. So have a look at lateral hip here as well. Sometimes you can't even lift people's leg that high without feeling that tension start to kick in. So I'll try and lift the leg like that if I can. It's a pain in the ass doing that though. That is a lot more restriction there than I was expecting. Any obvious tightness.
As in range, or as in resistance that you feel bringing it across,
And lateral range. Yes, okay.
Left lower back.
Okay, that's interesting. That probably felt a little more restricted than the left side from where I'm standing anyway.
Interesting.
Yes.
And I guess
Well, that would make sense.
ties in with what you asked before. Are you giving more weight to what you feel than what Anna says? Is when it's been a chronic or an acute on chronic situation, then what feels, their perception of what feels normal is altered.
Oh, totally.
Yeah.
So their ability to go, well, then that feels okay.
Yeah.
And not necessarily be able to
It's
differentiate
not too
right,
bad.
left or front, back. Yeah. So I don't feel anything because that's what I feel all the time.
Can't grab your phone out of your pocket there, and if we can get you lying on your side, so you're facing away from me here. So I would say out of all those movements, the two that were the most blindingly obvious in terms of the restriction were those last two we did just then, right? So you got a bunch of nerves that run from just under the last rib there, down towards the outside of the hip. A lot of them kind of terminate around the trochanter here. I'm just going to feel around the trochanter, and this is often a little bit pokey around here. Your tenderness back there.
That one is.
Yeah. And around the top of
one
that
is
there.
Not
Yeah.
too bad there.
Okay. And if we get in the front, it's hardly ever tender in the front, and so when I get in the front there, as well as asking them, I'm just checking in, you know, what sort of level of tension we've got in TFL. As we get further up TFL, that starts getting a bit chunky in there. Yeah. Is that sharp, or is that more like a weird, particularly get off me kind of
just
feeling?
like
Yeah, for sure.
that once.
So a lot of those nerves pop to the outside of the hip from above the iliac crest here. Sometimes you can feel a fair bit of restriction there, or coming just like onto the face of the ilium. I don't feel like it's having a great time back there. Tenderness there.
Not like the other spots.
Yeah, okay. But if you think about that bit there, and we come back here,
Yeah, back.
a little more sensitive there, hey? Yep. So this is probably superior clinical nerve, and you've got the lateral branch of the iliohypogastric nerve, lateral branch of the subcostal nerve, and then lateral femoral cutaneous nerve popping around inside of ASI, spreading back towards that trochanter and basically innervating all the tissue down the outside of the thigh, covering that whole ITB. So, we'll take a little bit of traction into some of the rami, some of the branches of that superior clinical nerve, lateral branch of the iliohypogastric nerve, a little bit of the subcostal nerve there as well, as they run down towards the trochanter, and then just above the ilium here, I'm going to traction that tissue gently forwards, gently back, just see which way it feels like it's kind of opening that tissue a little. And I'd say for most people, that feels like if I pull forwards, it does. For Anna, it's very much going the other way, right? Anything uncomfortable in what I'm doing here?
No.
Great.
So you're creating movement here and you're feeling change with the other hand, is it?
Nope, no. I've just tractioned all that tissue down, right?
Yeah.
And then I know there's some grommet holes up here, right? So I'm going, what do those grommet holes want to do?
Yeah.
Just to give me a little bit more space. If I'm honest, yeah, I can feel that under the heel of my hand here, but I don't want to tell people that the first time I ever show them this, because otherwise they're going to feel so bad when they can't feel stuff and they can't hold all the stuff together in their heads. So.
It's already way too long for me as a learner. I want to go back, if you know what I mean.
For sure,
yeah,
for
yeah,
sure.
So you're just doing the whole thing.
Yeah. So my plan in the course is to basically divide it into sort of upper body, lower body, and show people the lower body assessment, and have 16 people in the class or whatever, and you get half of them on the table, half of them go around, and you just drill it.
Yeah.
And you just do it, and you do it, and you do it, and you do it, and you do it, until you can at least do it kind of rote learnt, even if you don't know what the fuck you're doing.
Right. Yeah.
Just do the thing.
Yeah.
And if I can encourage like massage therapists especially to do that with people closed before they get them stripped off, right? Do a little bit of assessment on the table. Go, okay, it seems fairly obviously that there's a bit of restriction with this. Let's try a little bit of this cutaneous nerve work before you can get your clothes off. Reassess afterwards and go, holy crap, a whole lot of stuff changed. Then get into the massage and go, I'm not feeling all this regular tightness this person always comes in with, and kind of get the cogs kind of ticking that way.
I feel it's better for a day or two. It's like, oh, okay.
Yeah. So tractioning some of those branches down towards the trochanter there, lengthening those nerves, slimming them down through the little grommet holes just a little bit. Opening those grommet holes up a little bit, just giving those nerves a little bit more space to drain, keeping that traction on there, you're stimulating all those Ruffini's corpuscles with their slow adapting nature. So you keep that nice slow consistent input on there, and that will send really calming signals up to the sensory cortex. 75 to 80% of your sensory cortex is devoted to the nerves and layers of skin. So 20% listens to muscles, tendons, ligaments, and we've never ever paid attention to the skin, in regard to manual therapy at least, right?
Would you say the skin and the superficial fascia? And I mean like the
sure.
It looks like you're pressing very hard, but I know that you're not.
Yeah, I'm only pressing in enough to keep kind of that tension on that tissue there.
Yeah, but this is where we say
tension.
hold out techniques very dearly, but the mechanisms very lightly. Hey.
Yeah.
I reckon.
Yeah.
Very lightly, because
that's a good way to put it.
Yeah, because I can see this changing Anna right now.
Yeah,
like, I can totally see how it's working, but I'm like,
what do you see?
How is that? Oh, just like when he was tractioning this way, there was just a lot of tension there. It was pulling all of your tissue that way.
Yep.
And then the other way, it wasn't pulling anything
So
at all. Now you can just kind of
the paradigm shift, the crossing the chasm that Diane Jacobs talks about is moving to a model where you are basically considering everything from the point of the nervous system, right? So you
Tom Myers has already admitted that all of his work is pretty much not loudly,
but
it's
privately,
all because of
yes,
the changes that are happening in the nervous system.
Yeah, for sure. Great. So starting to feel a little more drop in tension happening around the outside of the hip here. Any particular sensations you're aware of? Can be nice ones. It doesn't have to be nice ones. But...
I guess when you first put it on, I felt tension, and then quite quickly, within maybe like 10 or 15 seconds, I could feel just starting to let go.
Yep.
And then I haven't felt as much change as time has gone.
So a couple of minutes-ish is how long is generally good enough to get some sort of change in the insular cortex. We're talking to the C-tactile afferents. And the insular cortex is a nice thing to get on side because that is where judgment calls are made about sensations. Is this a good feeling? Is this a bad feeling? Is this a threat? Are we okay here at the moment? Do we need to get away right now? And if you can convince that stuff that things are okay, that's great because it talks to the periaqueductal grey and the rostral ventral medulla, and they spend their time pumping calming neuropeptides and calming signals down the spinal cord to reduce that spinal cord withdrawal reflex, which is always ready to go and will tend to get amped up any time that there is nociception. And I think that's where a lot of the tension and stuff that people say is in their hip flexors comes from. It's adverse neural input from somewhere.
Yeah.
Meaning all that stuff is just always turned on.
Yeah.
Yeah.
Or ascending desensitization.
Lacking descending inhibition.
Yeah.
Great.
So just
so
to clarify,
up here. Yes.
You tractioned downwards, and then you felt here, and you felt the direction that it wanted to go, and you went where it wanted to go.
Whichever felt nicest.
Which is it's the opposite of go, oh, that direction feels tight, so I'm going to mobilise
that way. Yes.
tightness.
Exactly.
Yeah.
Yep.
Yeah.
Cool. All right.
And sometimes what feels like it's the right direction to go creates more unpleasant sensation, in which case we change and try different directions.
Keep lying back again. So interestingly, that internal external rotation didn't feel problematic at all this side, and that hip reach and height, I call it there, didn't feel problematic this side. It was just that adduction that was quite limited, and that's a whole heap more movement there. I wasn't getting your foot anywhere near the end of the table before. We start this into groin there. That's kind of where we're going with this other side.
You don't feel any back anymore, do you? You could see that.
That was the other leg.
Yeah.
We bring this leg across, and that was stuff on the left side of your back.
Yeah, nothing in the lower back.
Nothing here. Yeah, interesting. So one more thing I want to assess here before we get to the other side. Just going to keep this leg nice, relaxed. We'll let that drop out. That's pretty free and easy there. There's a couple of nerves around the front of the hip that are really sneaky, and I don't find you pick them up in all that leg extension that I was doing before. But I realised in fiddling around myself in the last few weeks that if you find restriction like that there, that's a fair sign you should be looking for something rather than down thigh, kind of up round groin.
Yeah.
Or lower abdomen even.
So that was quite a bit tighter than the left.
Yeah, and it looked good compared to lots of people, right? It's just quite an obvious difference between one side and the other there. So let's check inflection here again. Hey, that's a whole lot more movement. Pinchy?
Very pinchy.
More or less? Or the same?
Her body reacted much more sharply that time.
Yeah, I was going quicker.
Like,
yeah, sure. Okay. And going that way?
Yeah, it's still there, but not like
not
sharp.
awful like that was the worst one last time, hey?
I think so.
Yep. Right. So we know there's a bit of restriction around the outside of that hip. I'm interested to see how much that might change if we're addressing some of the stuff around the inside of the hip here. So bring this foot up on the table again. Just park your hand and tell me this. I'll get a nice place here. Rest this knee out of me. Sorry if this gets a bit pokey in here. Right, so I do feel quite a lot of stiffness happening down through here, and some funny bandy little bits just through there, hey?
Yeah.
I reckon that's nerves in the latest skin. They're just a bit stuck as they differentiate off that ilioinguinal nerve, which runs around to the inside of the thigh here. Quite sensitive in there.
Yeah,
yes.
like tickly.
And down here,
Not
not so much. How's that stuff?
Yeah, fine.
Okay. Just for comparison's sake. Man, this feels so nice.
Yeah.
Underlay under the carpet in my room.
Yeah,
God,
there's
there's
a
a lot of
lot of
effort.
effort into gliding around.
least of that ropey business. That whole inguinal ligament feels a whole lot softer here. Any tenderness this side? A little bit tickly. Which side's more tickly? Similar.
Right side, I think.
Okay. Let's just check in with internal external rotation. Yeah, don't like that so much. So going back to the start, I turned the leg in and went, that's lateral femoral cutaneous nerve. Go to it. And